All right, it's 8:05. Looks like this is everyone's going to be hopping on. So, yeah, my name is James. I am the technical content specialist here at RIVANNA, and I want to start off by thanking everybody that is here this evening for our webinar, Inside the Numbers, the State of Neuraxial Anesthesia, Key Trends That Matter. So, this program is based off of a report that we released in Q2 on neuraxial anesthesia. And our presenter today is Dr. Stephen Garber, and he's going to run through the report and give some interpretation to its contents. And after he's done presenting, we'll have a Q&A session where you can ask Dr. Garber any questions that you have about what he's been discussing. And we've also got product management and engineering staff on this webinar as well. So if you have any questions in those areas, feel free to leave those as in the Q&A as well, and we can direct those towards those staff members. So without further ado, go ahead and take it away, Dr. Garber.
Okay, great. Thank you, James. Thank you so much. Thank you, everyone, for getting on at this time. Really appreciate it. I'm Stephen Garber. I'm an obstetric anesthesiologist in Southern California at Saddleback Hospital. I've been there over 30 years. We are a center of excellence for OB anesthesia. Okay, before I get going, I want to tell you that there's a new restaurant I went to over the weekend. There's a new restaurant on the moon. Yeah, on the moon. And the food is fantastic, but there's no atmosphere. Okay. So with that being said, so we're going to be talking about, here's what we're going to be talking about, an introduction of where we are, current practices, some of the historic parallels, AI as a supplement, some real world results, and applying the principles to labor and delivery, and a conclusion, and some other dynamic phase stuff. One of the things I wanted to tell you, because we're talking about AI, and AI has, good people talk about it in good ways and bad ways. I just found out yesterday about a resource called Open Evidence, and I don't know if any physicians out there are on this. If you don't have this, you've got to get that. This is the equivalent of ChatGPT directed just for physicians. You have to use your NPI number to sign on, okay? And it is just amazing because everything you ask it gives you citations and everything very quickly. So for example, this morning, here's what I asked Open Evidence. What is the status with real-time needle visualization and performing an epidural anesthetic in labor and delivery? And it goes through a few paragraphs, and it has like citations, but here's the summary. In summary, real-time needle visualization for epidural anesthesia in labor and delivery is not yet standard practice. Pre-procedural ultrasound is the most established adjunct, while real-time pressure sensing and other novel technologies are promising, but remain investigational. So here's an example of AI, not in neuraxial anesthesia, but can be applied. And I really encourage everyone to get it. It's free, Open Evidence, and you can sign up for it. Okay, so what we want to kind of look at are some of the technological innovations that are around ultrasound imaging and AI, how the combination of those may be useful, and explore how AI and ultrasound can supplement neuraxial anesthesia techniques. So, and listen, I'm not saying abandon what we've learned. For example, the tried and true techniques that we use today are still applicable in many, many, many cases. This is a tool. These are tools that you can use in difficult situations, and I use them every single day. As an example, I remember when the first video laryngoscope came out, and I was asked to demo it, and it was the McGrath video laryngoscope, and I was like, this is fantastic. I go, one day, this will replace direct laryngoscopy. Now, move ahead to today. In our practice, now I'm not saying you don't teach direct laryngoscopy, you do, but in our practice, it has replaced direct laryngoscopy. And the reason why is interesting that no one would have figured this, but is the expense, because the direct laryngoscopes that we use are just completely disposable, and they're more expensive than a blade for the McGrath. So everyone is using the video laryngoscope. So what are we based on now for most of our epidurals and spinals is a landmark technique. Okay, they are safe and they work the majority of the time, but patients with complex anatomy, I know in my practice and here in Southern California, every single year BMIs are getting higher and higher. It's harder to palpate the space. And also you get patients, you can see the picture below that, with abnormalities, scoliosis, or maybe they have hardware in their back. So using the palpation techniques, you rely on your tactile feel, your loss of resistance, palpation of the space, and they are very helpful, safe, and have been used for many, many, many years. But sometimes you need something else. You need something else to find the midline, to find the epidural space. And remember that obese patients have a 2 to 3 times higher failure and difficulty rates. These highlighted things, I'm not going to click on them, but in the presentation, if I click on those, it goes to a paper or it goes to a citation. So all of these things that you see in the blue that are clickable are citations or references, and you can come back and ask RIVANNA about those if you want, because I'm not going to go off to those today. So let's look at the evolution of ultrasound in peripheral nerve blocks, and then we'll look at in spinals and epidurals, okay? So when I was training, we did not have ultrasounds for peripheral nerve blocks. It wasn't available yet. So what we did is we did landmark techniques and anatomical techniques. You know, for example, to do a brachial plexus block at that time, you did an axillary artery through and through, which the needle, you go into the axillary artery to make sure you're getting arterial blood, then through the other side, and then deposit your anesthetic. Now, of course, nowadays, no one would do that. It's not safe to do. And we have ultrasound, which gives us real-time vascular visualization and nerve structure delineation, continuous needle trajectory during insertion. And this is the standard of care now for doing peripheral nerve blocks, is with the ultrasound. And if we're looking at spinals, epidurals, what are people using ultrasound for now? Okay, so pre-procedural anatomical scouting for optimal site and depth. I use the device at least once every shift that I'm on. It's a handheld scouting device with AI. And one of the things is that it allows me to find the midline within about 20 seconds. Okay, and that to me is huge, because that is, for me, is like half the problem. Some of these patients, you can't feel anything. You don't know exactly where you are. You identify the midline, and then go ahead in the next steps, identify the inner space and the depth to the epidural space. A very handy tool to have. And my colleagues, when I first brought this on, I've been using it for about 5 years now. When I first brought it on, I just kind of left it and said, you should try this. And organically, people started using it, okay? So what we're seeing is the imaging results result in improved first pass success. And again, there's been studies for that, particularly with residents, even when experienced attending anesthesiologist, improving the first pass success. So what about, there are people that are doing real-time needle guidance with these techniques. The thing is, you can't do a midline approach because you can't visualize the needle, but you can do a paramedian approach. I'm not a paramedian fan just because I like the midline approach. And to do the real-time needle with this technique, with the ultrasound, you've got your syringe, it's difficult, but there are people that are doing it with raw ultrasound and with these AI enhanced instruments as well. So let's look at some of the impact on neuraxial anesthesia with AI and where we're heading and what we're going to go to. So first of all, when you look at automated landmark identification, so again, you can identify the midline quickly and you can identify a space. And what we're talking about right now is to pinpoint the space and then mark the space and then use that space. So you're not doing real-time visualization with what I'm talking about right now. So when you look at what we can get improved patient satisfaction. If you have a patient with difficult anatomy, very high BMI, you can't really feel what's going on, or they've had bad scoliosis or instrumentation. You're going to improve the patient satisfaction because you're going to have an easier time finding where to go and getting in there. And trust me, with my use of these devices, that's definitely what's happening in this realm here. Pre-procedural planning. So I will sometimes get a call from the obstetrician and saying, can you come to my office and do a consult on a patient? Either they had a very difficult epidural prior, or their first one, or they have scoliosis or some problem. Can you come and do a consult and look at the patient? So I will just tuck the tool into my pocket, and I take it over, and I can easily scan a patient in the doctor's office and either tell them, oh yeah, look at, I can pretty much see, I'm going to not guarantee anything, but I can see a space here. I think we're going to be able to provide you with a labor epidural, or if you can't, if scanning is very difficult, it may be the time to tell the patient, you know, I'm sorry, it doesn't look real good. We should probably think about some other pain modalities for you for your experience in labor and delivery. So it's very handy in that way. As far as minimize risk of complications, in these difficult patients, these devices, the AI, the ultrasound combined, will give you a pretty accurate depth of the epidural space. And I don't know if you've been following the recent, in the past year or maybe even longer, about post-dural puncture headaches. These headaches that we were trained, okay, if they're severe, you give them a blood patch and they're going to get better and they're going to be okay. Well, we are seeing a certain percentage, and they're not insignificant headaches that become chronic headaches for months and even years. So these can develop into chronic, serious, debilitating headaches. And we want to do everything we can to help prevent those. So this tool can help you decrease your incidence of wet taps by identifying the space and the depth and using that as a guide. Again, we're not talking about replacing our clinical judgment with something that just takes over for us. It's enhancing and tools to help us practice better, to be safer and more efficient. So and this study here had an 81% increase in first pass success in obese patients, and I think they were greater than 35 or 40 BMIs. Again, there's a study that is related to this. So when we're looking at, again, immediate recognition of the midline and the epidural space and a depth estimate, so it reduces the needle placement time and can give you a trajectory for your needle. So this is a patient. I wrote a case report up on this patient, and this patient was a 42-year-old gravida 2 para 0 with severe scoliosis that, again, I was asked to do a consult on. So I actually had her come up to labor and delivery, and I think she was 32 weeks or so to do a consult. And I put her in one of the labor beds and had her, bend over and did a scan. And I was very fortunate. I was able to scan and see a spot, see an epidural space. So I told her, I said, there's no guarantee this is going to work, but I see a space. And so we will definitely try once you come into labor. And I was called in, and when she was in labor, and the same space I scanned, the one that was previously noted by me. And I was able to also put a chart in case I wasn't going to be there. I put a note in the chart with photos of the area and these similar photos for any colleagues that would need that information. I then went ahead and did the scan and placed the epidural. She was in labor for about 12 hours. It worked very well, and she delivered vaginally uneventfully. In addition, she came back, so this was a year and a half ago, so she came back about 6 months ago, or four to 6 months ago, for a repeat vaginal delivery, and I was able to scan to do the same thing, and she delivered vaginally as well. So in this instance, the Acura was very, very helpful and really gave me confidence. In the pre-op, it gave me confidence and the patient, which is really nice, because then those 8 weeks, she wasn't as worried. Again, I don't give any guarantees, but it certainly helped me look at her spine and give me some confidence that I'd probably be able to be successful with the placement of an epidural. So let's talk about some real guided, needle guided stuff that's going to be coming around, okay? So when we're looking at dynamic execution, when we were originally talking about just scouting right now, what we're doing is, just to review, we're using the device to put a mark. You scout, you see the depth, and then you take it off, and you remember the depth, et cetera. Okay. So real time, and like I said before, there are people doing real time needle visualization with a paramedian approach, but there's work now being done with AI, with an ultrasound probe that can do live needle tracking with just a two-handed technique. This is going to be coming. You're going to see evidence of it. And actually, I'm working on a study right now. We're going to be doing our second set of patients here in August. And it's very, very exciting stuff, because to me, this is sort of the final frontier, the last frontier, to be able to do a live needle tracking with epidurals. Okay, again, it's not going to be for every patient, the easy ones, but it will be very, very helpful in the very, very difficult patients. For routine practice right now, we're doing the scouting and the AI enhanced, and again, looking at the depth, trajectory, and marking the space that you have. So we're just going to compare right now. I spoke about this just a second ago, but just to review. So scouting versus real-time guidance. So scouting, again, mark the insertion site, use the device to find out where you need to go, how deep you need to go. You advance the needle at the mark site and go. Your confirmation of placement is loss of resistance if you're doing CSE, CSF, et cetera. So with real-time guidance, and what I'm talking about is not the paramedian approach, but you're going to be able to see the real needle advancement. The AI identifies the space, it identifies how far you have to go, it identifies the spaces around and shows you where to go, and the needle will track down. Now, what you're going to do, obviously, is once you get down near, you're going to use your loss of resistance. It's not designed to, enter the epidural space without the other tactile stuff that we use. And again, this is very exciting. We're going to be seeing this in the next year, I hope, or year and a half or so. So just be on the lookout for this great technology that's coming forward, that's going to add to our toolbox. So here are the things that are here now, and all of these have come about during my years of practice. Okay, all of them, they didn't exist when I first started practicing. So when I first started practicing for C-sections, we did epidurals. We just didn't put the epidural needle in and gave a pretty large bolus of local anesthetic because we didn't have any pencil point needles. So right now, what's here now? AI-enabled ultrasound imaging, which we talked about, where you can scout and find a space, mark it, and then use that to find the epidural space. Real-time ultrasound imaging. There are people that are doing that, able to do that with highly technical and a little more difficult, but it can be done. Needle designs, again, pencil point needles, the needle through the needle for CSEs, et cetera. Safe pharmacological agents, they're better than they have been. Low dose infusions, low concentration. And also we're getting, for example, we use Exparel for our tap blocks, which is encapsulated bupivacaine, which lasts 96 hours doing tap blocks, and it has reduced opioid consumption by 85%. It's absolutely amazing. And they are also working on a preparation that would be a spinal preparation. So imagine a patient comes in for labor and you do a spinal and you give a very small dose of Exparel, which lasts 40 hours with little to no motor block and pain relief. So that's coming sometime. There's always something on the horizon that's exciting to talk about. PCEAs, we know that, that's really changed our practice. we run a background of 10 cc's or so, and then the PCAs, and it really has improved patient satisfaction and anesthesiologist satisfaction as well. And what's coming? Again, the AI-enabled imaging and needle tracking. Multiple approaches to this. What I'm talking about is a midline approach that is going to allow you to be able to not have to hold an ultrasound probe and be free to do your procedure as you do it. Very exciting with live needle tracking. The augmented reality technologies. Now, I haven't really experienced these. I know some colleagues have with the glasses or stuff that you can do sims and dive into anatomy and physiology. I mean, those are here now also. The non-opioid adjuncts I talked about, what people are working on, and some of those are here as well. AI support for training, and I'm sure that's going to be entering, and probably already is entering, the residency programs as we speak right now. And medical record integration, where everything can go in the medical record in real time and be enhancing that with AI as well. So this is a very exciting time. I mean, I'm very excited about the stuff that's going on with the AI and ultrasound, meshing those together. And I think we're going to continue to see advancements. And again, it's all about how can we make the experience safer and more efficient, better outcomes, better patient satisfaction. And that's where all of the focus for me doing this stuff. I go all around the country talking about all of this stuff that I've just spoken about, because I'm very excited about it and I use it, and it's changed my practice. It's absolutely changed my practice, and my colleagues as well. So we are dependent on the device that we're dependent on right now is the scouting with the AI, the handheld device. And it's so useful in those times when you have a very difficult patient. So what we're looking at is what's here, that's here, and what's coming in the future. We're going to look at AI-assisted ultrasound with live needle tracking, and very exciting stuff. So again, thank you so much for being on this. I think yes, that's the last slide, for being on this webinar. And I welcome any questions. We have a whole panel of experts here. If you have any questions, please go ahead and let's get them answered.
All right, thank you so much, Dr. Garber. And,
Sure.
Guys, just use the Q&A option there at the bottom of your screen, and let's see what you got. Okay, so I just saw one that popped up in the chat, Dr. Garber.
Yeah.
Can the device detect a tethered cord?
No, the device cannot detect a tethered cord. No. So yeah, you would be you're talking about tethered cord like in the cauda equina, I believe. So within the subarachnoid space, I think that's what you're asking. No, it cannot detect that. So you just have to be, very careful, or yeah, it's not going to help you with that.
All right, so here's a comment I'm seeing here that someone's saying the Acura gives me a distance that's not, they're having trouble with accuracy of the distance there. You have any tips on how you manage that?
Well, what I do is I give the distance, plus or minus 1 to 1.5 centimeters. And I find that with that, I'm going to be accurate. So when I'm getting, when my interspinal ligament and I'm really engaged with my epidural needle, I'm going to be watching my distance carefully and to be within that distance. And I really haven't had our problems, because I definitely don't go to the distance where the device says it is. I stop well before that. I'm definitely engaged. But then I find that I hit the epidural space, it's fairly accurate for me. And I've heard that comments from other people. And that's my recommendation, is to use that as a guide and plus or minus, and just to know you're in the relative area, and then proceed with your loss of resistance with saline or air or whatever you use.
Okay, so there's a couple coming up in the Q&A as well. Can you see those, Dr. Garber?
No, I can't. Oh, hold on. Yeah, there we go. Okay. Okay, so the first, there's a great question. How high of a patient BMI can this device handle from your experience? Okay, can everyone, you can hear me okay, right?
Yep, yep, yeah.
Oh, okay.
Yeah.
Okay. Yeah, so that's a great question. I've used it on a patient with a BMI of 62. And, what I do is I approach each patient as if there's no limit to see what I can do, because there's no hurt in scouting and see what I can do. And also applying enough pressure to the adipose, to the skin, to the adipose, to get some compression, which may decrease, the distance. I'll be able to see better. So I will try it pretty much on anyone, and just to see the results I get. And if I don't see anything, but I haven't had an experience yet of a patient where I was unable to scan and get some sort of results. Okay, and then how useful have you found the device in supermorbid? Again, the same sort of questions. I found it very useful. For one, identifying the midline. I mean, I can identify the midline in just about anyone, and that for me is huge. So identifying the midline and then proceeding. So I have found it very, very useful. And like, again, I'll bring it out on anyone to try, because there's no downside in trying it and seeing where you are. If for you it doesn't work, then you'll have to go to another technique. But I guarantee you can at the minimum identify the midline, which is going to be a great starting point. I consider that. Okay, how long is the learning curve to implement the Acuro in one's practice? Okay, that's a great question, and it is really not very long. So the way that I describe and the way to use the Acuro is to start with a normal patient and just bring it out and scan. And the way that I scan, and I've got it very effective for myself, is what I do is I get the patient and I prep with the ChloraPrep. I have the Acuro standing next to me with gel on it. I open my epidural kit, and I'm all ready to go with my kit open. And then I do a scan, and I mark the spot. And then I take another ChloraPrep, then put my gloves on, and then go. So that way I'm kind of moving continuously. And if you use it on normal patients, on 5 normal patients, 4 or 5 or 6, you're going to get the hang of it right away. It's going to show you exactly what to do and where to go. One of the tricks is using the little pop-off thing, that the spinal navigation pop-off device that marks the spot, and looking at that. And one thing that I like to do with that is to show people and show myself is you take that, just the pop-off part, and put it on your arm and press down on your arm so you can really see what you're looking at. And then you go, right in the center there. And what I use is I use a needle, but I use the hub of a needle, the round part, and marked out right in the middle of the skin there. But if you do that a few times, 4 or 5 times, you're going to be fine. And again, I use this on very thin patients. If I have an extremely thin patient with tight spaces, I'm worried about a wet tap. I'll use it, scan it, and see, okay, I'm pretty comfortable with the depth. And I see, like, oh, is it very shallow or not? Sometimes it can be, these patients don't have a shallow epidural, even though they're very thin. So I'll use it on a very thin patient with tight spaces as well. Okay. There are a few handheld ultrasound devices on the market. What makes Acuro different from the others? So I have not used any of the other ones, so I'm afraid I really can't tell you what the differences are, because I've only used the Acuro, and I've been very pleased with it. I didn't even realize there are some other ones out there, but I'm sorry I can't really answer that question very well for you. Okay, I've used the Acuro and was not able to effectively use the marker. Okay. Which is the best way to use that? It either got stuck at the end or wasn't stable. Probably a me thing, but wanted some tips. Okay, so I'll go through this again because that's a great question. Because look at when you're using something like this, if the first time you use it and you can't get it, doesn't work, you're going to say that it doesn't work and it's not useful. And I know that's very important in the learning curve to get going. So here's what I do and what I instruct people in the use of it is I hold the device with my thumb. So I'm holding, pretend that it's going this way. And I have my index fingers. There's two little wings on the marker piece, that pops on. There's two little wings. So I scan, and then when I find the spot, I have my index fingers right here, and then I push with my index fingers, and it may even pop off right there of the device. But that way, I've got the device held firmly. I have my index fingers here. I don't have to move and then move. So I don't have to move and lose the space with my index fingers. And then I push with my index fingers pretty with a lot of pressure because I want to create that. And then immediately can see that and then mark with the end of the needle. So try that technique and see what you think with both index fingers when you're scanned. Once you're in the right spot, then use your index fingers and press the device in there. Those are all great questions. Thank you.
Hey, Dr. Garber, this is Steve with RIVANNA. Thanks for hopping on and going through the presentation. I just want to jump back to that last question about the difference with Accuro in some of the other devices on the market. So we made Accuro, we changed the frequency of the ultrasound so that it can see up to 12.5 centimeters in depth, which makes it really great, like Dr. Garber was saying, really efficient for the high BMI patients. Typically, any other ultrasound, handheld or other, usually gets typically pretty blurry as you get to the 6 or 7 centimeter mark, just as those typical ultrasounds are picking up on soft tissue and other things like that that get in the way. But with that frequency change, the Accuro was made specifically to see the bone anatomy, which allows it to see further. So when that BMI is 40, 50, 60 plus is when it's an excellent tool. So I just wanted to answer that.
Yeah, thank you, Steve. I appreciate that. Yeah, I didn't really mention the limits of the depth, but yeah, that's absolutely correct. And I was actually just reading one of the resources I clicked on one of the resources in the program here because they had a study about first pass success with raw ultrasound versus the Accuro. And the raw ultrasound, they couldn't see the depth. It was exactly the same. It was blurry, and they really couldn't identify the structures they needed to identify with the raw ultrasound.
All right, so there are a couple more questions here in the chat. I don't want to miss these here. So let's see. I think the next one is, are there good videos for training? Which in my experience, we have videos on our site and on our YouTube channel that show some pretty good instruction for how to get started using it. But so that's kind of my input for that one.
Yeah, I agree. Yeah, there are some very good videos for the use. And let me understand if you still have the trial program in place.
Yes, we do.
Yeah, you do. Okay, so this is this is like the risk-free trial. It really is. And this is how I got the use of the device. I was at the SOAP meeting in 2019. Cruising around, and I saw the Accuro at that time, and they said, hey, look, we'll send you one for 30 days or 60 days if you want to try it. And I was like, yeah, of course I want to try it. So he sent it to me. I had nothing to lose. And I actually probably kept it, maybe longer than 30 or 60. However, that trial enabled me, number one, to the learning curve, and then to go on YouTube and look at the videos. And the resources at RIVANNA, I would call the rep and go, listen, I'm having a problem with this or this, and okay, here's what we can do. And actually, they ended up sent me another unit. And they said, well, I think we have some improvements in this one. So I got another unit to try, and then we went and purchased one because I liked it. So you can do an absolutely risk-free trial. You don't even have to pay for shipping. So, and it's a great way to really, see if you like the device. And this is what I always tell people. I go, look at, you can use this or you cannot. One of the frustrating things I run into is someone that tells me and that's doing OB anesthesia. Well, I've never had a problem doing an epidural. Why would I need that? I'm like, okay, see you later. So all of us have problems here and there. And this is a tool, and you can use it or you cannot use it. This is what I tell people. I like it and I use it. It's very useful. Other people, maybe they don't find it as useful. But if you can find something in your practice that in the back of your mind is like, this is something that I can probably use. It's going to help me. So why not use it and try it?
Yeah.
Yeah, just to expound upon that with our current trial. So we have a 30-day free trial, like Dr. Garber said, no risk. We ship it to you. We'll send you the training videos, any other materials, quick start guides to kind of get you started. Also offering virtual sessions where you can hop on a meeting like this and just ask questions, do a training with a spine model through, a Zoom chat like this. And yeah, still an option.
Great. So I think this is the final question I'm seeing right now. And maybe this is a better one for Steve or maybe Adam. Have you completed any IRB studies with this device to determine if it reduces ADPs?
Off the top of my head, we've done studies. I'm not sure specifically for that. I don't know if Adam has the ability to chat here, but I'd have to look into that and see. We've done a lot and a lot of adjacent studies with that, but specifically, I'd have to double check for you. But I can certainly get back with the study if we have done one and let you know.
What I don't understand, reduction in what?
I can read it again. Have you completed any IRB studies with this device to determine if it reduces ADPs? That's the
What,
question.
what is an ADP? I don't know what that is.
This is Adam. I was just unmuted. I think it may refer to accidental dural punctures.
Yeah.
Oh, yeah. Oh, okay. Yeah. Sorry. I didn't quite get that terminology. IRB studies are done. Well, let's see. I don't know if there's actually the studies, but I can guarantee you that it does. Now, I know you want the science in the study, but if it definitely, in my practice, it definitely does. And that's just my clinical experience, my only time, me experiencing that. But I mean, if you got like a really thin or a difficult patient and you know where you're going to be going and you have a good idea of the depth, it's definitely going to reduce the accidental dural puncture, in my opinion.
All right. Last call for any questions. And yeah, is there any expansion on the answer to that last question, Adam or Dr. Garber?
Yeah, this is Adam.
Yeah.
We've done, between 5 and 10 IRB studies with the device. Studying the dural puncture endpoint is challenging because it is a relatively rare event. And so in a single study, to show statistical significance in a reduction of dural puncture, you would really need thousands of patients. So instead, we look at surrogate endpoints like first pass success, fewer needle misdirections, fewer needle puncture events. And those are correlated with, the incidence of these dural punctures, because extra needle sticks are generally correlated with challenging patients. And like Dr. Garber was saying, that's typically where you do see dural punctures more commonly.
Okay, so there is one uh, question that just popped up here in the Q&A. What is the price of the Acura, and is there a subscription fee?
All right, that's all, Steve.
Yeah, yes. So the device itself is 29.95, so just shy of 3,000. No subscription. The end tips or locators, as Dr. Garber was mentioning earlier, that does the indents. Those are 195 for a box of 24. Depending on usage, our typical customers, again, if it's one or two providers, may go through a box or two a year. If you're at a larger facility and you have a lot of different hands-on, maybe somewhere 3 to 4 boxes a year, but it kind of depends on usage.
All right. Well, I think that's it. I don't see any more questions. So with that, I think we're going to go ahead and wrap this thing up. I just want to say thank you to everyone that signed up and attended this webinar. We will have a recording of this presentation available to all registrants and everyone that signed up. And keep a lookout for more of these webinars. We really want to start doing these regularly. So yeah, we'll plan on having more of these informational programs in the future. And one final thank you as well to Dr. Garber for hopping on and presenting for us today.
Yeah, thank you for having me. I really enjoyed it, and I hope it's makes a little impact in your practice. Thank you.
All right. Well, thanks everyone for attending, and be on the lookout for some follow-up.